All right, everyone. So thank you for joining us today. We're going to get started right on the hour, be respectful of everybody's time. Thank you for joining us today for our webinar on understanding dementia and its different causes. It is my pleasure to welcome Dr. Ben Williams and Dr. Tracy Myers today to discuss some of the different types of dementia and some of the different ways we can evaluate for this and different ways that you can support either yourself or a loved one, and how we at Synapticure can support you as well. So I'm just going to start off with a little quick introduction to Synapticure, and then we'll do some introductions to everybody on the call today. So for those of you who have not met us yet, Synapticure is a patient-centric virtual outpatient clinic with a goal of transforming the lives and the outcomes of people with neurodegenerative diseases and their loved ones. We were founded by a patient and his family, Brian Wallach, and his family. Brian has ALS, so that's actually where we started back in 2021. We started our clinical practice in 2022. And we've since expanded to different movement disorders, including Parkinson's disease, Lewy body dementia, Huntington's disease, and some of the atypical Parkinsonism syndromes. And we're also now seeing dementia as well, which is why we invited you to today's webinar. So what do you get when you join Synapticure? So we are, again, a comprehensive virtual care with a variety of specialists who are experienced in neurodegenerative diseases, including dementia. So we have subspecialty trained neurologists, psychiatrists, neuropsychologists, nurses, licensed care social workers, and many more, genetic counselors, insurance navigators, who really are all here to help you and your loved one navigate the difficult journey of dementia and other neurodegenerative diseases. We provide wraparound care coordination and caregiver support. We offer referrals and education about clinical trials. We are covered by most insurances. And we are happy to help with prior authorizations, helping with insurance navigation, disability. And most importantly is we're happy to work with your current team. So your primary care docs, if you have a general neurologist, if you have a neurologist that specializes in the disease that you have, we're happy to work with them too, to give you extra support between your visits. So with that, I'm going to stop my screen share. And it is, again, my pleasure to introduce two of our fantastic clinicians, Dr. Ben Williams and Dr. Tracy Myers. Dr. Williams, if you'd be so kind as to start us off, tell us a little bit about who you are, kind of what your background is, and what brought you to Synapticure.
All right. Well, strap in, everybody. It's a long story. But at any rate, I spent my time right after college getting a PhD in neuroscience. But once I did that and I did a postdoctoral fellowship, I decided to go into medicine. After I did all of that, I ended up doing my neurology residency at University of California, San Diego, which happened to be a hotbed of Alzheimer's disease research at the time. Now, that was not by design, it just happened that way. But that did influence me for the rest of my career. I went into private practice for many years, and I was a general neurologist for many years. But eventually, I got back into academia, and always as a memory specialist slash Alzheimer disease person. When I made this change, I was out in West Texas, so I joined part-time the faculty at Texas Tech, but then did a full-time job at University of Texas Southwestern in Dallas. Was there 5 or so years, participated in their so-called ADRC there, Alzheimer's Disease Research Center, which is one of the NIA funded sites for Alzheimer's research. There's about 30 of these in the country. And then from there, I got fortunate to join the Wake Forest faculty and their brand new ADRC at the time. And I was the one and only so-called cognitive neurologist, or sometimes we're called behavioral neurologists, and help them, get off the ground, so to speak. But circumstances being what they were, I needed to step away from North Carolina and join my family. And so I did that just 4 or 5 months ago. And still had a desire to share what I know about these diseases with patients. And then I happened to get connected with Synapticure. And the thing that really sold me on Synapticure was what Dr. Jamie has already told you, which is it's after the visit care and care coordination. Uh, that is so sorely lacking in almost all places otherwise. And it certainly was lacking uh, both at UT Southwestern in Dallas, and less so, but still lacking at Wake. They made some efforts there. So I am really looking forward to not only then doing my thing, which is trying to puzzle out just exactly what disease that's going on, but then uh, being able to actually affect uh, some care management that extends beyond the actual clinic visit. And I will stop there and let Dr. Jamie take it.
Dr. Myers?
Yeah, my story is not as long as Ben's. I'm just teasing. Yes, I'm a licensed clinical psychologist, and my background is in neuropsychology. When I was in grad school, my first practicum experience was at a memory disorders clinic in Florida, and I was hooked pretty early on in terms of understanding dementia, doing testing. So my background as a neuropsychologist, I went further and did my postdoc fellowship in geropsychology and neuropsych, University of Miami, and really a lot of interest in helping understand people's condition as part of the neuropsychological evaluation, and then the treatment, right? So it's one thing to diagnose, but then what do we do after? And so at heart, I'm a clinician, I'm a therapist at heart, even though I have the neuropsych background. So I really love following people. I've had the privilege throughout my career of following people for many years. After graduate school, I worked at a traumatic brain injury and stroke rehabilitation outpatient clinic, and then worked for the Department of Mental Health and Addiction Services in Connecticut. And I've been following some folks for 20 plus years now with different brain injuries and neurodegenerative challenges. And it's a privilege to be with people, helping them, accompany them on their journey. So yeah, I'm really excited to be part of Synapticure because I get to do just that, which has been really to accompany people, family members, clients, as they're navigating different challenges around their cognition, to provide support, intervention, psychotherapy, and then to work with a team like Dr. Jamie and Dr. Ben, who, we can work together. And I think that part is really awesome. So we're not in silos, we're able to interact with each other. So if there's an issue with somebody and they need to have a medication change, I can write to Dr. Jamie and we can have a conversation. So that wraparound care, like you're saying, Dr. Ben, doesn't happen that much. And so we have this ready-made group of folks that really want to interact and share and improve clients' lives. So
Fantastic. And then just a little bit of background on me. So I started out in undergraduate school, actually. My major was biology, but my minor was both psychology and gerontology. And I actually started out in a research lab in Alzheimer's disease doing some early vaccine work. So this is a couple decades ago now. So really got interested in cognitive impairment and dementias. And then as I did medical and graduate school at Emory, moved up to Atlanta and did a combined degree program there, and got really interested in not just the cognitive issues, but also movement disorders, which is what ultimately led to my graduate work in movement disorders. And then ultimately, after I finished my neurology training, I did a fellowship in movement disorders as well. But as with many of the neurodegenerative diseases, even if it's not a primary diagnosis of dementia, many of the disorders that we treat, so Parkinson's and Huntington's and things like that, often have cognitive issues as part of that. So even though it's not my specialty, it's certainly something that we treat quite regularly. And I'm so excited to have really a rounded out team to really address all these issues. I was very lucky at Emory to have some phenomenal neuropsychologists and behavioral neurologists that were always at ready access to be able to ask questions and run, issues by. So that was one of the things that really drew me to Synapticure is just like you've all said, is having that team approach and having people to really collaborate with, and then being able to support patients. I know, we worked so hard to do as much as we could when I was at Emory, but a lot of times people still need support in between visits. So I'm happy that Synapticure is able to do that. So as I mentioned, as a company, we started out in working with ALS because that's what Brian Wallach has, and that's what everybody knew well. But the goal was to always expand into other neurodegenerative diseases. And so as part of my joining when we launched the clinical program was to help build out the movement disorders program. And so we've been able to do that. And then, as I mentioned, more recently, we've expanded into to dementia as well. And so we really just wanted to spend the rest of the time today just giving you a very brief background about, what does it mean when we say dementia? What does it mean when we say mild cognitive impairment? What does it mean to talk about a primary or a secondary dementia? And, is it really different? And then what are the different ways that, we can support you, how you can support yourself or your loved ones? I think these are all the most important things. Unfortunately, we can't answer any questions today about very, sort of personal things, but we certainly can answer sort of general questions about various topics. So, Dr. Ben, if maybe you could start, I know we were talking about this earlier, this could be a decades-long course, but maybe you can walk us through a little bit about sort of the background of the, mild cognitive impairment and dementia and sort of the different
Sure.
categories.
Yeah, sure. So these diseases, with one exception, they're neurodegenerative diseases. So that means nerves degenerate. That takes time. So these people that are going to have one of these neurodegenerative diseases, like Alzheimer's disease, they're going to be, thinking normally, and then very slowly will not be thinking so normally. And we're talking over years, years and years. So people will pass through a phase that's called mild cognitive impairment. And there's an operational definition of that, which goes like this. If a person were to undergo cognitive testing, they would have a problem. And I'll just leave it at a little bit of a problem. We can measure it, but just a little bit of a problem. But they're still functionally independent. Eventually, though, going to continue to have more and more problems, again, over years, but they'll get to a point where they're going to have problems with or more significant problems on cognitive testing, and they're going to need some help. They're going to have some functional problems. And when you're at that point, you more or less meet the definition of having a dementia. And then you can go from mild to moderate to severe in your dementia. Just things just continue to kind of roll downhill, if you will. So I just want to impress upon you that when we use terms like mild cognitive impairment and dementia, there's an actual definition to those. They're not just thrown around willy-nilly. As to the neurodegenerative diseases, the main ones are Alzheimer's disease, which constitutes probably about 60% of diseases or more, and I'll get to the more in a moment. So if you think about it, that might be a smaller number than you might have thought about. You might have thought like 99% were Alzheimer's disease, but it's not quite that much. And then the next one is kind of bleeds into Dr. Jamie's world of dementia with Lewy bodies. And then the third, which constitutes about 10% of all dementias, is a category called frontotemporal dementia, or FTD. Now, sprinkled along all of those is something that we really don't call neurodegenerative, but it doesn't really matter because it causes trouble, and that's vascular processes. So vascular trouble can be by itself. It is possible, but it's more commonly mixed in with Alzheimer's or dementia with Lewy bodies or frontotemporal. And to make things even more complicated, there are plenty of folks, in fact, probably the majority of folks that are going to have the pathology of dementia with Lewy bodies are also going to have Alzheimer's disease pathology. So you can see how complicated it gets. And this is why when I see a patient, I am really puzzling very hard. All these programs are running in the background of my mind, trying to, to figure out, okay, which of these is going on or what combination is going on. And this is part of the reason why your doctor doesn't have so much time to help you with your care after after you leave the clinic. Well, how do I take care of the problem with sleepless nights and that kind of thing? It's just a very complex business. There are certainly plenty of other diseases that can cause dementia. There are other neurodegenerative diseases like Huntington's disease. It's pretty rare. There are infectious diseases like HIV or syphilis in the more distant past that can cause it. Metabolic problems can do it. One of the things we check for is your thyroid function and your vitamin B12 level, because those are two things that can cause cognitive problems and can be fixed, fortunately. But those are very, very infrequent. There are immune diseases that can cause cognitive change. Usually it's on a faster scale than what we've been talking about, but those are worthy of consideration. And believe me, there are others as well. There's a rather extensive list. But Alzheimer, dementia with Lewy bodies, vascular, and frontotemporal are kind of the big players.
And maybe you could comment a little bit on, does everybody that is diagnosed with MCI go on to develop dementia?
Yeah. So no, because MCI is agnostic as to etiology, meaning I could diagnose, Dr. Jamie right here. For some reason I say she's got MCI, but that does not mean that you have Alzheimer pathology or Lewy body pathology or any other pathology. It just means you meet those criteria that I talked about. You got a little bit of trouble on some testing. You've noticed some difficulty in your thinking, but you're still functionally independent. Everybody that meets those criteria, they're going to have MCI, but it doesn't tell us what's causing it. So people can get MCI. I've had more than one patient, and I bet Tracy has seen this too, where they were actually just under a lot more stress than they were aware of. And they tested out and came across as MCI, and then you see them a year later and they're different. And I've had them actually just say to me, Doc, I was under a lot of stress. I didn't even kind of thought it was all that stressful, but it cleared up, and now, I'm thinking a whole lot better. Or you get folks that are working at a pretty stressful job, and they either cut back or stop or change it or some way somehow, and then all of a sudden they're doing better, they're thinking better. And of course there's a lot of medical reasons too, and I don't want to hog all the time, but let's say you have untreated obstructive sleep apnea and you get that treated. Well, you can start thinking a whole lot better, and you might even not have MCI anymore. You could be normal. So if you are abusing alcohol and cut way back on that, if you started getting some exercise, that signal may not be that strong, but it can certainly help. So I'll stop yammering and let Dr. Jamie guide us with the next question.
And just for clarity, we mentioned it sort of in the beginning, but just to make sure everybody understands that MCI is what we call mild cognitive impairment.
Right.
And I think maybe Dr. Tracy, maybe you can talk a little bit about when we say cognitive or cognition, is that just memory, or what all does that include?
Yeah, so cognition includes lots of different functioning. So we often think about, when we say mild cognitive impairment, we think someone's memory's going, right? And that could be one of the things we see, but typically we see changes in different cognitive areas. So the key cognitive areas we assess if we're doing a screening or an evaluation, we're looking at memory. And not just memory, memory actually has many different components. We can talk about immediate memory, more short-term memory, and more long-term memory recall. So we also have attention and concentration. And interestingly, sometimes people are actually having difficulties in attention, but it can look like memory. Because we think about our brains, like if we're not getting the information in, it's impossible to remember the information, right? Like a computer, if we don't save it, we're not going to be able to access it, right? So attention and concentration. We're also looking at visual spatial skills, processing speed, which is really interesting to think about. If someone has some slowing in their processing speed, it may be more difficult for them to take in and do something with the information. Again, it can look like a memory issue, but in fact, they haven't sufficiently had time to process new information. We look at new learning. We look at something called executive functioning, which could be a whole webinar just about that, but that looks at problem solving, task switching, something called cognitive flexibility, which means like the ability to shift sets if what you're doing isn't working. And even a little bit more psychologically, insight and judgment. Is the person aware that they're having some difficulties? In some of the forms of dementia, people are not aware, especially more of the frontotemporal dementias, where people may not even realize that they're exhibiting different behaviors. So cognitive functioning is pretty broad, and when we do a neuropsychological assessment, we're assessing each of these categories, and that helps us understand the person's overall functioning and also how they're doing in different areas. And what we see, even with someone with mild cognitive impairment, is that it's often patchy. It can be one area, someone may have a lot of strength still. Someone's language skills may be very much intact. That's another area. And then other times we'll see someone may have impaired language, but their visual spatial skills are still strong. That helps a little bit more with, to your point, Dr. Ben, about like, how do you figure out which condition someone has? So if someone has more language involvement, that helps us understand it may be one kind of dementia versus more executive functioning and personality behavioral changes, which might be more of a frontotemporal dementia. So one of the benefits of doing a neuropsych assessment is it helps us understand a little bit more about the pattern, and that pattern may be consistent with one kind of dementia over another.
And can you maybe elaborate a little bit on sort of what you mean when you say visuospatial issues? What kinds of things?
Yeah. So classic visual spatial skill might be looking at a picture of blocks and then having to replicate the design using blocks. So puzzle-like tasks. Functionally, it may be like driving, directions, knowing how to get from point A to point B, recognizing visual cues in the environment, right? So someone who may be struggling with visual spatial skills may get lost. Things don't look familiar that used to look familiar, for example. So that could be a little bit of visual spatial, a little bit of memory issue happening. And different, depending on motor skills, sometimes we'll see difficulty putting objects together because of the visual spatial issue, but also because of fine motor. So there are lots of regions of the brain that are overlapping in terms of their function.
And then Dr. Ben, maybe you can touch on, and again, this is, we'll kind of keep this brief, but maybe a little bit about, so what causes, or what are sort of the key features of some of the different major categories of dementias?
Well, the neurodegenerative diseases are all characterized by the accumulation of abnormal proteins. And each one of them has a different protein or proteins, because in Alzheimer's disease, it's two different proteins. And I bet most people have heard at one point or another about amyloid, at least. And then, so that's one. And then the other one is an abnormal protein called tau, T-A-U, tau. Likewise, in dementia with Lewy bodies, it's a protein that's called alpha-synuclein. And the FTDs are more complicated. Some of them are tau, some of them are different proteins. They got weird names. We don't need to belabor them at this point. So that's how it works, and that's how these diseases were identified. There's all based on autopsies done on people, and the brains are prepared in such a way that they're very thin slices you can see under a microscope, but then you put special stains on them that'll stain for these proteins specifically, and lo and behold, after decades and decades and decades of work, came to pass that Alzheimer's, the classic Alzheimer's person is going to present with primarily with memory problems. There's a lot of variation there, but and dementia with Lewy bodies is going to present with some other odd things, not so much memory, but visual hallucinations and acting out dreams at night. That's a weird thing. I always love asking people that when they look at me like I'm crazy. Why am I asking that? And they also have something called cognitive fluctuation. So their attention, which Dr. Myers here, Tracy said that so attention can be specifically affected in DLB. And then in the FTDs, the classic ones there are behavioral problems, true comportment problems. These people are just not acting in a socially acceptable way, typically, or they can have language problems of various kinds. So you can have FTD with no behavioral problems, but it's all language. So again, we could talk for hours and hours and hours about these things. There's so much that's been learned about these diseases. What else can I help you with there, Dr.
So
Jamie?
a common question that I get, and in fact, I talked to a patient about this today, is sort of what's the difference between Parkinson's disease, dementia with Lewy bodies, Lewy body dementia, Parkinson's disease with dementia. So what I generally tell people, and feel free to add anything to this, is generally speaking, Lewy body dementia is sort of an umbrella term that includes, just to make it confusing. So Lewy body dementia, LBD is the umbrella term. And then dementia with Lewy bodies is sort of one form. And then Parkinson's disease with dementia is the other. We talk about them sort of separately, but they're really kind of on a continuum. From a diagnosis standpoint, technically, dementia with Lewy bodies is the involvement of cognitive changes that are consistent with dementia, and that it can include also hallucinations, beliefs about things that are not true, so what we call delusions, among some other things, and then the appearance of symptoms that look like Parkinson's disease within a year of each other. Most of the time in that category, the cognitive impairment is often the more troublesome issue. Right. And then the motor or the movement symptoms or Parkinson's symptoms are sort of take a backseat to that. And then there's Parkinson's disease with dementia, which is a clear diagnosis of Parkinson's disease for at least a year, could be 30, and then the subsequent development of cognitive issues. And once you get to that point, the cognitive issues can often look very similar. It's they're not strikingly different. They may progress a little more slowly in Parkinson's disease with dementia, but in the grand scheme of things, they're often very similar. And the treatments for both of those are often very similar as well. One of the questions that came up, and you kind of touched on this a little bit, and feel free for either one of you to talk about this a little bit, is does change in personality and anger management go along with one type of dementia versus another?
It's a really good question. So yes and no. So I mean, so anger management, when we think of the classic frontal temporal changes, we're often thinking about changes in personality, like you were saying, Dr. Ben, about like inappropriate outbursts or things that, and they deviate from how the person normally is, right? So it's a real change in a person's regular personality. But other conditions too, even Alzheimer's type dementia, you can see anger management challenges because, there's a psychological component too, right? Adjusting, getting frustrated with caregivers, people feeling embarrassed or ashamed. So there can be a very understandable psychological response that can produce anger with any of the diseases that we're talking about today. And then some that are more predominant where there really is a lot of dysregulation or emotional lability, where we see lots of mood swings, and anger being one of them, where we see that is related to the frontal lobes and some deterioration in that area of the brain.
Absolutely. So one of the questions that often comes up is, does everybody with ALS or Parkinson's disease, always get dementia? So if you'd like to comment, either one of you, a little bit on that.
Well, I'm no ALS expert, but my understanding of that is that although it does happen commonly, I don't think every ALS patient develops dementia. And what was the other one?
Or Parkinson's
Parkinson's. Oh,
disease.
yeah. So Parkinson's. Yeah, definitely not all people with Parkinson's. It's again, it's a significant percentage, but no. So they don't all go to dementia.
And one of the things I often tell patients from a movement or from a Parkinson's standpoint is sometimes you'll notice cognitive changes. So probably the most common thing I hear in my clinic is delays in recall. It's all there. My grandmother used to say this. It's all, I have my Rolodex is full. It's all in there. It just takes me longer to get to it than it used to. So, and I think, Dr. Tracy, that gets to your sort of the processing speed. It just takes longer to get there than it used to.
And sometimes it's like a retrieval issue, just like you said, it's there, but finding the right file where we stored it, and that's where, like when we do a neuropsychological evaluation, it's important, of course, to try to figure out the pattern and the level of impairment. But actually, the part that I think is really the most important is the recommendations and strategies. So if we know, for example, if someone has a memory and a retrieval issue, then it can be really helpful to help, develop strategies. So if I'm having trouble retrieving information, these are some things I can do. For example, we can have Post-it notes. We can take time to before trying to remember, like that tip of the tongue phenomenon. So if we can't remember something, we can set it aside. We can use different kinds of devices on our phones, et cetera. So it's helpful to know where the memory issues are so we can develop strategies to help people.
So if somebody thinks either they have some cognitive changes or they think maybe a loved one has some cognitive changes that are noticeable, what's the first step, and what does evaluation look like?
Well, most people are probably going to see their PCP. And of course, if they're Medicare age, they're supposed to get yearly at least a brief cognitive assessment, and that might be the trigger or the proof. So then, most and this is a statistic that I actually read off the Alzheimer's Association website recently, but a super high number of PCPs are going to refer on. So, which is interesting. I don't think that same statistic would have been true 30 years ago. But at any rate, they refer on. And so you're going to get referred probably to a neurologist or sometimes a special gerontologist if they have expertise in this area. And sometimes it's even psychiatry, but not in the classic sense of this is a psychiatric disease. It's just there's some psychiatrists that are very skilled in this world. Any rate, if you come to see me as a neurologist, there are guidelines. So yes, you have to take a history. That's standard, medical practice 101, but you need to be taking the history with a knowledgeable informant, because patients themselves are often not capable of telling the history correctly. And so that can sometimes be a very interesting situation. But you need to do at least some kind of objective testing. It can be a pretty short for a neurologist, and then if things go in certain ways, you need to get a neuropsychologist involved, like Dr. Tracy here. But there's some basic labs that are done. They're very simple labs, nothing exotic. You're just looking for some little metabolic trouble. It is standard of care to have an MRI of the brain, preferably MRI. CT is okay if you can't do an MRI. Now that's not so much to prove that you've got a neurodegenerative disease or you even have Alzheimer's disease, because you really can't tell on an MRI. You can see some things that are suggestive, but you can't really prove that one way or the other. So why do you get it? Well, you don't want to be fooled by some other pathologies that are potentially treatable. Now, these are pretty infrequent, but you could have a mass in the front of the brain in particular, and some of these can be removed, or you could have like water on the brain or blood on the brain, and some other conditions. Or you could have a lot of vascular disease, which would begin to tell you what the problem could be. So MRI is needed. So uh, that is the standard testing. What else is out there? This now becomes a very complex world when you go, what else is out there? Insofar as imaging goes, there are some PET scans that can be done. There's an amyloid PET scan, which is looking for that protein that I mentioned a while back to see if that's in the brain. There is a metabolic PET scan. It's called an FDG PET scan, which can be very helpful in telling us, hey, what parts of the brain are not metabolically active, so where there could be trouble. There is really more on a research basis, a tau PET scan that's out there. The trouble with these tests, although the amyloid PET scan just got FDA approved, I mean, like recently, like within the last couple of months, and that's because of a whole nother issue, not because these were just just came to be, because they've been around for a while. But the fancy scans are often not covered by insurance. The other thing you can do, and is covered by insurance, is to undergo a spinal fluid evaluation, because you can send that off and get all kinds of good information about the various proteins and some other things potentially that are bad actors in the brain. But people tend to recoil at that because, although doctors call them lumbar punctures, the public calls it a spinal tap, and most people have a very negative opinion of spinal taps, which as neurologists, Dr. Jamie, we see it totally differently. But that's where it's at. And there are a couple other tests that could be run, but they're a little bit off the beaten path, like a brainwave test, an EEG, that kind of thing. The new thing that's coming along, and it is close to prime time, I mean, it's super close to prime time, are blood-based tests for amyloid and tau. Not so much for, well, there is one for alpha-synuclein. I don't know how much you use it, Dr. Jamie. And there really isn't much for the FTD abnormal proteins. But these are things that I do think we are right on the cusp of using. Again, they are actually available. I mean, you could draw the blood and send it and you could get a result, but it's paying for it is, how's that going to happen, and that kind of thing. But I think this world is going to loosen up pretty quickly. And we're all in favor of a blood test. PET scans are expensive. They're not easy to do. They're very material intensive, equipment intensive, and you really need some special radiologists to read them correctly. Research centers have these galore, but just out in the general public, it's not really there. So a blood-based test that gives us a kind of a number, if you will, or at least a probability, is sort of the holy grail that we're all waiting for.
So when someone comes into me and says, I think I'm having memory trouble, right? We certainly check medications, make sure that, obviously there's lots of medications that can cause some memory difficulty. So we go through that. We go through all the testing that you talked about, Dr. Ben. So if we get through all of that and we think, maybe there is actually something going on, Dr. Tracy, can you talk a little bit, you've touched on this a little bit, but maybe a little bit more about what does it mean when we say cognitive testing? What does that look like? Is it, what's the difference between, 1 hour, sometimes you hear 4 hours and 8 hours,
Yeah.
and is it always in person or can that be done virtually as well?
Yeah, so it's a continuum of kind of the screenings that Dr. Ben was talking about. Some of you are familiar with the mini mental status exam or the MOCA, where we're talking about a test that might take 20 to 30 to 45 minutes. And typically they can be helpful as a screener, but we're not going to make a diagnosis based on that. It gives us an indication, especially for someone who is experiencing some cognitive decline or reported cognitive decline. And then the screening indicates that as well. That gives us information to go on for a full evaluation. So a full battery, and now, kind of post-COVID era, we can do some of it remote. So initially, it was always face-to-face, maybe a few computerized tests, but typically it was always in the office for approximately 2 to 4 hour sessions, sometimes more, depending on how extensive the battery is. Now there's a lot more flexibility, so some of the pieces can be done remotely. Entire batteries can be done remotely, particularly if they're streamlined. So a typical neuropsych evaluation for dementia is usually around 4 hours or so. Because we don't want to just do one test. We typically want to have a couple of different measures so that we're really accurate in being able to give a diagnosis or a probable diagnosis. Like we were saying earlier, we don't, unless there was an autopsy done, we typically were giving probable versus or possible versus a definitive diagnosis. And then the other piece again is the functional piece. So, we're talking about PET scans and tests that are looking at what's happening in the brain. And neuropsych testing and psychological testing helps us see how is the person actually functioning. And the psychological part is really important too. Someone I know wrote in Facebook about how hard it was to watch their dad struggle with personality changes. And so, these are things that are really important, not just to work with the client, but the caregivers, family members too, around psychological adjustment. So part of our batteries, we also do psychological testing to help us see how is the person coping. Is there a co-occurring depression or anxiety we can treat to make the person more comfortable? And also with the family members too. So that psychological piece is as important as the cognitive piece when we're looking at the whole person and really wanting them to feel well and to be able to develop coping skills to manage what's happening.
So one question that has come up is, how do you compare, right? If let's say you have somebody who maybe didn't finish school versus, Dr.
Yes.
Rocket scientist, like how do you
Yes.
compare, what one person's normal is versus another?
It's a fantastic question. So neuropsychologists got crafty over the years and realized that very same dilemma. If we compare people with different educations, ages, right? Do we want to compare an 80-year-old to a 30-year-old, right? We know that the brain and some functions slow down. So we have something called normative data where we're comparing people to their peers, essentially. So if we test somebody who's 80 and has 12 years of education, we actually have data from people in that same healthy people that took the test, and we have a sample. So we're able to compare to the right cohort, so to speak, so that we don't have these gaps in terms of like comparing someone who's older to someone who's young. And that helps us see what a normal 80-year-old is going to do, which would be different than a 30-year-old. Education matters on some tests, right? So some tests that are more based on prior learning, some of our intellectual measures, the IQ tests, have a lot of education background pieces to it, your general fund of information. So that does take into account education as well. If someone has a lot of cognitive reserve, they don't show the deficits early on testing. And so typically they may look very clean on testing, but they know that there's some changes that are happening. So our testing doesn't always pick up everything right away also.
Yeah. I always remember I have a patient, I use the rocket scientist example because she was literally a rocket scientist. She's
Yeah.
like, I'll blow every test you have out of the water, but I can't do my job the way I used to.
Yeah.
She noticed that difference.
Yeah. So yeah, good.
So what about people, little things? If, you forget something, you walk into a room, you don't remember what you came in for, you forget some, a word or a date or something. What, when do you start to worry about, and either one of you feel free to answer, when do you start to worry about what is just sort of, sometimes that happens versus something that's more serious?
Dr. Tracy, I'll let you handle that. I'll bet you have a
Okay.
better answer than I do.
It's such a common thing, like, and I think because of our heightened awareness of cognitive issues, many of us have had that feeling, right? I'm sure, like, oh, it's taken me longer to remember things, or the name, phenomenon, like, yeah. And so that is normal as we get older. Anyway, right after 40, there are some changes in our efficiency that don't mean that we have cognitive decline, right? So that's one thing. So I do normalize, and I do a lot of normalizing. But like you were saying, Dr. Jamie, like if someone says, I'm not able to do what I normally do, so it's a change in your level of ability to do things you normally do. So that's one thing I start to look at. Are they having trouble doing their job? Are they having trouble maintaining the finances? Suddenly they start bouncing checks when they never did that before. So it's like, when they're not able to keep up with the demands of their life, they get lost in places that are familiar, right? So it's when it exceeds what we'd say is kind of normal aging, distractibility kind of demands. Now, sometimes people are stressed. Dr. Ben, you were talking about this. You said like if people have enough stress in their life, it affects our cognition. So I always look at that really carefully. And in fact, that's my first thought. Like, let's look at all the psychosocial things happening. Has there been a death, a loss, some kind of change happening, a change of job? So trauma, we know people that have experienced PTSD can interfere with cognitive functioning. So we really want to look at all of those things before we necessarily think it is a cognitive decline. And then if it doesn't improve, like to your point, Dr. Ben, if they, they went to a psychotherapist, they made a job change, and they're still noticing these impairments, that gives us a lot more data. Like we need to go further and do a deeper dive.
Yeah. And I think too, we're kind of in this age of so much information overload. And I mean, I know for me, even when I'm at work and, it's like the chat's going off and regular text messages and the phone's ringing and emails going and patient messages and the kids are, asking questions. And, you have all of these things coming in. Sometimes it's really just, I think, to get maybe to your point before, Dr. Tracy, about just attention. There's only, if you've got $1 worth of attention, you can only spread it so many ways before it starts to get, to just pennies. So we have a lot of good questions coming in, and, these are all topics we could really talk about forever. But I'd love to get to some questions. So I want to touch base on one of the questions that you had mentioned before, Dr. Tracy, about, sometimes, a loved one may have some behaviors that are different for them, that are sometimes, either mildly or sometimes very inappropriate. I think it's one of those things that I think for all of us as clinicians at this point, nothing surprises us. And while it certainly may be embarrassing for you as somebody that's experiencing it or as a family member to bring up, we're always here to talk about these things. I will often bring common symptoms up to sort of break the ice, to say, hey, listen, this is something that we commonly see. And I like to bring it up because sometimes people don't realize it's related. So it could be things like we see sometimes in Lewy body dementia, thoughts that their spouse is being unfaithful, things like that, you don't really think about maybe related to an underlying disorder. So just to touch on that, please feel free to let your clinicians know if some of these things are happening, even if you're not sure. It may be related, it may not be related. Sometimes it's due to medication. So some of the Parkinson's medications can cause some what we call impulsive or compulsive disorders. So sometimes they're the common vices like excessive, eating, drinking, gambling, sex, pornography. But sometimes it's things like excessive cleaning, or, we use the term hobbyism. You sort of get, sort of compulsively into a hobby. So sometimes they're sort of benign things, so you think, or so it sounds. But when it starts taking over kind of your daily function, we think about that as well. So one of the questions that has come up a couple times now is, if a family member has dementia, so let's say my mom or my dad has had dementia, does that increase my risk? Sort of what's the role of genetics in the various types of dementia? And this is a question, but
yeah. So, boy, I wish I just had a slam dunk answer for you. But if we just limit it to Alzheimer's disease for the moment, it has definitely been established that the more first degree relatives that you have, that a person has had dementia, probably Alzheimer's dementia, yes, that does increase your risk of getting dementia, getting Alzheimer's dementia. Is there an actual number I can provide you? I'm sorry, but I cannot. I'm just I'm sure some people out there, some researchers have tried to estimate it, but nothing. There's no number out there that really sticks that I know of. Um, it turns out that in Alzheimer's disease, there's a very, very small number of cases where people can get the disease with a single mutation of a gene, and these are known. But these are very different because typically the disease runs heavily in families, and so goes back several generations, and the families know about it. It's not a secret, and part of the reason they know about it is because the disease will come on much earlier than typical everyday Alzheimer's disease. By earlier, I mean like the 30s and 40s or 50s, that kind of thing. So we can set that aside for the vast majority of us, and then what's next? Well, uh, there has been so much research done on this, but it turns out that there are somewhere between 20 and 40 sort of risk genes that if you actually have the riskier form of that disease, it kind of gives you a little bit of an increased risk of getting the disease. So you can, or it's possible to generate something called a polygene or polygenic risk score, but these are nowhere near ready for prime time clinical use, that kind of thing. And it probably goes back to the idea that, the more first degree relatives you have, they probably harbored more of these particular genetic variants, and that puts you, at greater risk. So, so it's not that genes are not important; they definitely are. It's just it's not simple, unfortunately. Now, there's one other gene that is, I don't want to hog it too much, but there's a so-called ApoE gene. It gives you the greatest risk. There are 3 forms of that disease, and if you have one of the particular forms, it can increase your overall risk. Well, if you get 2 of them, it can increase your overall risk like 8 to 12 times the average risk. Uh, with the other combinations being a whole lot less. So that is the one gene that if you're kind of digging into the Alzheimer, I'll call it literature, or just educational sites, you'll probably run across a discussion of the ApoE gene. So FTDs, about 20% of those are due to a known mutation. And I am not up on my DLB genetics. Dr. Jamie, do you happen to know what that is? I thought it was low, but
Yeah.
yeah,
Oh, yeah, no clear sort
yeah,
of what we call mono or single gene causes. There are some things that increase risk, but
right. So yeah,
nothing that really, not, I think one of the important things at this point is nothing we can act on, nothing that changes
exactly.
our management. Um,
Yes, that's a good
I
point.
I think it's beyond the scope of today's conversation, but I know that, for the ApoE4, so if you have 2 of those copies,
Mhm.
that may change whether you're eligible for certain types of treatments and stuff. So some of those are important to get, but
They, you're absolutely right, and they've gone from something in the shadows to something that's now being discussed, and there's going to be a lot more people that are going to get an ApoE assessment real soon because of
so
that.
yep.
Mhm.
So, we have a little bit of time left. So there's a couple questions that come in with, so somebody says, many of us at the beginning of the AD, FTD, or other dementia journeys have had a very difficult time getting a diagnosis. And I think, we all understand how important it is to have a correct diagnosis. So one of the questions is, are we at Synapticure or, via telemedicine able to make that correct diagnosis? And then also, how do we work with somebody's local team to really help support their care. So I will say from a Parkinson's standpoint and from some of the Lewy body dementias, a lot of times the diagnosis for us can be made clinically, especially if a lot of the hallucinations, some of the delusions, paranoia, things like that start to come up, assuming that there's not any other sort of mitigating factors. So we didn't really touch on this, but there's an entity called delirium, which is an acute change in thinking and memory due to some sort of active problem, like a urinary tract infection or things like that. But that's by definition is reversible compared to the dementias. But sort of outside of that range, if somebody's developing a lot of these symptoms, a lot of times that, sort of moves us in that direction of the possibility of one of these dementias. And we can certainly treat accordingly and do additional testing. But what about some of the other syndromes? Do you feel like that most of these can be, assuming we can't do, we can order blood testing and scans to be done locally, but what about the rest of it?
Well, the trying to make a diagnosis is difficult. So the more tests that you do, the better the chance that you'll get to an understanding of this disease is going to be more likely Alzheimer's or more likely a frontotemporal or something like that. The problem in the past has been that since there were no disease-modifying therapies out there, once you started to describe the tests, spinal fluid test or PET scans, et cetera, and all of these are not covered, and this, that, and the other, most people would just back off. And they would just, I mean, I could pretty convincingly say, look, I know it's neurodegenerative. I just can't tell you which abnormal protein you've got. I mean, I can make some guesses, but I can't say that with total conviction. I wouldn't bet the entire ranch, at Vegas on that, on my answer. But now that we are in an era, a budding era, where there is a disease or a couple of disease modifying therapies for Alzheimer's disease, and with the government now saying that they will support payment for at least amyloid PET, et cetera, I think we're entering into a new phase where we're going to get more data, and we're going to be able to make better answers. And sometimes let's just say you did an amyloid PET and whatever else. Let's say you did both, and spinal fluid amyloid PET, and they were both negative. Then you might go, well, shoot, then I mean, I still don't know what it is. But the thing is like, well, no, but you're backing into the other diseases, the diseases we know about. So maybe we need to start looking at one of the FTDs or DLB or something like that. So so even a negative result can be helpful in winnowing down the possibilities of what's actually going on. So my answer to that is, the more tests that you're willing to do and able to do, the better the answer we can come up with. So.
And I think that answer and this question that has come in sort of segues into probably our final is, what can Synapticure do to help out with, by working with your current care team to make sure that you have the right diagnosis, to make sure that you have the best care possible. So certainly, if there's blood work that needs to be done, if there's, certain types of imaging or other testing, lumbar punctures, things like that need to be done, we're happy to coordinate with, if you have a team that you have locally already, we're happy to coordinate with them to get those things done. If you don't have those things or you're not sure where to get those things done, we're happy to really help coordinate, not just saying like, oh, call this place and you can get it done, but we'll reach out to those centers. We'll reach out to get those appointments, get those things scheduled for you. It's one of the biggest things we hear from a lot of people is, you're dealing with, and sometimes, especially if you've just been diagnosed, it's just you're dealing with the sort of overwhelming, the grief that comes along with that initial diagnosis. And then where do you start? Who do you call? How do I know that this place is better than this place? And this PT or that speech therapist or this, what type of scan and who do I go to? So, all of us at Synapticure, our care coordinators, everybody are really, here to help guide you through all of those things and figure out what exactly needs to be done. And there are occasions, there are certain things that we can't do on your exam that, we may actually have to have somebody, be able to evaluate those things in person. So we're happy to coordinate that as well and really keep those lines of communication open with your care teams that are local. So we make sure that, you're getting all the care that you need, but also, if there's more than one cook in the kitchen, that we all know what everybody's doing and we're not duplicating things or we're not, saying things that are in opposition to each other. So with that, I'll put up this last slide, just if anybody wants to scan this or write down the phone number or the email for any information. Dr. Ben and Dr. Tracy, thank you so much for joining us today. Any parting words for us?
Yeah, I think the other piece is just with Synapticure, you have a group of people to accompany you, because there are like so many things we've been talking about today about the diagnosis, about getting the proper treatment, and then having support along the way for caregivers. So I think that piece is really unique to what we offer, so that we can help the whole person and the families as well. And so I'm really appreciative you all took the time to join us and hear a little bit more from us.
Great. All right. Thanks, everyone. We will have a recording of this posted shortly. We'll let you know when that's available. And thank you, everyone, for joining us today. For any questions that didn't get answered, we'll try to answer those, later on, either on the Facebook site or also in the blog summary that will come with this recording. Thanks so much, everyone. Have a great night and have a great Thanksgiving.